the IRIA Preventive Radiology session today. This session, we want to call it as the Preventive Radiology OP. It is an outpatient department, a virtual OP that we are running here with radiologists, hepatologists, and the industry partners also giving you certain insights on the particular subject of non-alcoholic fatty liver disease, the clinical features, the diagnostic workup, and the management strategy. It is very important for us to focus on non-alcoholic fatty liver disease because we have seen the data that is coming from various parts of India that shows that there is a considerable increase in the incidence and prevalence of fatty liver disease, and which has got lots of long-term consequences in terms of need for liver transplantation. When even in a place like Cochin, 20 to 30% of liver transplants are due to non-alcoholic fatty liver disease and fibrosis consequent to that. So you can imagine the long-term issues of a high incidence and prevalence of non-alcoholic fatty liver disease, which is now increasingly being called as a metabolic dysfunction disease spectra. So we have got a window of opportunity now. The preventive medicine, preventive measures can be taken now or otherwise. Recently, there was a study in Trivandrum which says 49.8% of adult population had some kind of fatty infiltration or fatty liver disease. So 1 out of 2. So what does that say? And 5 to 10% of them can go for fibrosis and cirrhosis and may require liver transplantation. So unless we do we actively and aggressively do a work on fatty liver disease, and when it is in a stage of reversibility, the 20 to 30 years down the line, only thing we can do is to enhance the surgeons to have skill, enhance them for more and more liver transplantations. So now the window of opportunity is with us, the radiologists, the hepatologists, the gastroenterologists, the physicians, and to make aware of our population about this danger that can come if we ignore it, and to also to make aware of the healthcare institutions, healthcare administrations, and the governments also about this impending danger. So that is the reason why we have started this IRIA Preventive Radiology initiative and started on the non-alcoholic fatty liver disease campaign in our Preventive Radiology OP. To inaugurate this session, we are privileged and honored to have the Executive Committee member of International Society of Radiology and also the Executive Counselor of Asian Oceanian Society of Radiology, a past president of Indian Radiological and Imaging Association, whose vision has turned IRIA the last 5 to 6 years into a very dynamic organization with lots and lots of activities at in the Yuva wing, the Shakti wing, the Samrakshan, the Preventive Radiology, you name it, a lot of activities. Indian Radiological and Imaging Association has become one of the most vibrant professional medical organizations in this country. Let me introduce Professor Dr. Heman Patel, the Executive Committee member of International Society of Radiology. And may I invite you, sir, to inaugurate this session.
Thank you, Rijo, for all kind words, and wonderful evening to all friends who are participating just like me in this wonderful seminar. It is my pleasure to be part of this Preventive Radiology initiation. The hero of this program, Rijo, I actually thank you for starting this mission, and I'm overly confident that we will come out with some concrete data down the line, maybe after a year or after 2 years, how many patients we detected before any clinical symptoms they may appear, and how much we have contributed for this great cause. Why I'm confident? Because when you started Samrakshan, I had all apprehension during that time, how we will achieve the fetal-maternal well-being and the data you are talking about. But you proved, you proved me wrong also to some extent that, within such a short span of time, We have published so many papers. We came out with the concrete data in our country, and it's a now, we can go to the Ministry of the Health and we can tell them also these are the measures we need to take to prevent certain kind of the disorders, and we can intervene as early as possible. Today we are also happy that my dear friend Sharad is also contributing for this seminar. Dr. Gaurav Mehta is also here, so all will get the insight about fatty liver, how it will transform, and how early we can pick up and intervene at that very point. I also thank you, Team Mindray and Mr. Kakambram and Ashwini and all friends who are supporting such kind of really good cause and the noble cause for radiology and also for the society. Rijo, I'm very sure that to start with the fatty liver, we will also pitch in for the other aspect of the preventive radiology wherever we can help to the society. And this is the long process. We cannot change the whole thing in a year or two, but the way looking at your passion, your involvement, and your commitment to do something for such kind of thing, I'm very sure that we will able to achieve this. With this, let's enjoy the whole session, which is the very vibrant on the breast, on the elastography of liver, and along with that, which are the associated findings we should look for, and what will be the clinical implication of the same. So once again, thank you so very much, all the organizers, for inviting me for this wonderful program, and my best wishes for the same. Thank you.
Thank you. Thank you very much, Dr. Heman Patel, sir. That was the Executive Committee member of International Society of Radiology, Executive Counselor of Asia-Oceanian Society of Radiology, and the past President of Indian Radiological and Imaging Association for the inaugural address, and the message that is well taken. So we will take this mission forward, the preventive radiology. First, let us focus on the fatty liver, and there are other areas that we will be focusing on preventive cardiology, especially focusing on the atherosclerotic vascular disease, atherosclerotic coronary artery disease, and then on multimodality imaging in cancers, and also screening for the endocrine diseases, especially for chronic kidney disease, of which one of our speakers today, Dr. Sharad, is a pioneer in, and Sharad will be coming back in these sessions with the sessions for the screening for chronic kidney disease with imaging biomarkers at a later time, in the near future itself. So we are moving on to the academic session. Let me invite Mr. Egamparam, the marketing manager of Mindray, to give a short address on their technology that has been widely being used in the non-alcoholic fatty liver disease, especially the 2D shear wave elastography. And I'm happy to announce that Mindray has partnered with the IRIA for a multicentric study to assess the prevalence and magnitude of non-alcoholic fatty liver disease, and also in Asian Indian population, and also to compare the diagnostic effectiveness of transient vibration control transient elastography, otherwise called as Fibroscan, versus 2D shear wave elastography using the Mindray's zone sonography technology, versus MR elastography, versus biopsy in possible cases. So this is a multicentric study that we have already started. 20 centers have already enrolled, and the process is already on. So let me invite Mr. MC Egamparam to give a short address on the industry perspectives on and the recent developments, recent technological developments that Mindray wants to contribute, wants to share with us. Over to you, Mr. Egamparam.
Thank you, Dr. Rijo. I think it was really a fantastic introduction, and we are really very privileged to be part of this IRA's multi-center study. And fortunately, the new emerging technology as a gold standard called zone sonography is changing the way people look at the shear wave elastography. And we are already seeing across the world, our technology has been embraced by many radiologists, and also even some of the gastroenterologists who have been looking this with very curious interest as well. And we would like to thank also Dr. Heman Patel for this great support, and also his august presence today makes absolutely a great evening. Thank you. Sir, can you stop sharing so I can share a small presentation in the next 2 minutes? There is a screen to be. Okay, I will now share the screen, sir. Can you see my screen, sir?
Yes, yes.
Okay,
Yes.
thank you, sir. I think this is the technology which we have started around, let's say, 3 or 4 years ago. And it was a part of a development which came from our subsidiary in the North America at Palo Alto in California called Zunair. And we have now migrated this into a whole body imaging. And the primary consideration is also for radiology. And just to tell you, at this moment, as Mindray, we have over 2,500 people involved in R&D. And absolutely, as you can see here, in the last 50 to 55 years since we have seeing ultrasound, our zone sonography beginning the last 7 to 8 years, changing the way we are looking at ultrasound. So why this zone sonography? That's a primary question. We all know as an ultrasound user, there are 3 primary components called spatial resolution and temporal resolution, which is a frame rate, and also tissue uniformity. And each of them has its own challenges interlinked. So if you have an increased spatial resolution, you need to have a less frame rate. This is a challenge. Similarly, if you want to improve focus depth, again, your frame rate will fall. So in order to overcome this, we have come out with the technology, and it's called zone sonography. I'm moving a bit fast for a want of time. And zone sonography involves in channel data processing, and is also software driven. And this is basically also a technology which is evolving. And this technology, which has been evaluated by Frost & Sullivan a few years ago, and they have rated as the next industry standard in ultrasound, and it's a 2 generation ahead. So what is zone sonography technology and how it works? This is the game changer in terms of the acquisition process, supported by the powerful architecture, but it has 4 strong pillars called advanced acoustic acquisition, dynamic pixel focusing, sound speed compensation, and channel data processing. I'll go a bit quickly now. And this is how it looks. If you see, this is a conventional line by line acquisition, which is by every other company. On the right side, you see advanced acoustic to the zone sonography, how fast it is, and able to gain at least 10 times the rate at which. So you have more time to do the post-processing in the acquisition, post-acquisition and display. And that's how it works. And obviously, you can see from the first pillar called advanced acquisition, how it works. This is how it is able to compute and display, which is actually taking certain amount of time through line by line scanning. And you can see finally the image is formed. But here on the right side is zone sonography. So this is the best, the first example. And if you want to see a representative image, you can see on the left side a conventional ultrasound, and on the right side with a better temporal resolution as well as less artifacts, you can see the image with a difference as well. And this is a typical image out of it. And second pillar of it is called dynamic pixel focusing. We all know in the current ultrasound, we need to have multiple focal spot, which reduces while improving the image quality, but also the frame rate gets reduced. In order to overcome that, we have this called dynamic pixel focusing. And on the right side image, you can see a uniform pixel with infinite focus. And this is how a representative image is formed with the multiple focal spot. And you can see again, with this kind of a multiple focal spot, you have to have a certain amount of time, which means reduced frame rate. On the right side, you can see through that. That's how the image is formed. And again, it improves there. It has no bearing on the frame rate, but however, it improves the image quality across the depth. So this is how you can see a representative image. You put a focal spot here, you see a deer. You put another focal spot, you see somewhere a little bit better. But in dynamic pixel focusing, you see the entire image, but also you see also some more information like another deer at the background. And this is a phantom image of 16 centimeter. If you go at the depth of around 15 centimeter, you can still see on the right side image, very good resolving of pins. The typical images using that as well. And the second most important thing, or the third most important thing, called sound speed compensation. Typically today in every ultrasound, the acquisition is fixed at 1,540 meters per second. 540 meters per second. We know that this is not exactly a fact. Every tissue has its own sound speed as per the body mass. It changes also according to the patient. So we have now come out with a process called sound speed compensation. It takes multiple images and takes it to the channel data memory and obtains the right speed for that particular patient and takes the best representative image and gets that image on the screen. So this is how you can see a better sound speed compensation. Here you can see the image on the left side by a conventional ultrasound with a very fatty liver with a diffused image. You can hardly see the diaphragm. On the right side, you can see improved spatial resolution as well as much more detailed depth and diaphragm as well. Okay, the fourth most important component is obviously the total recall of the image. That means whatever you are able to acquire, you should be able to use it. But in the conventional ultrasound, 90% of it is dropped at the acquisition, post-acquisition, before it gets processed. But however, in our channel data, 90% of the image, it gets used. What does it mean? It improves the total image, improving the diagnostic confidence. That's what we are talking about. So these are the four fundamental pillars. And of course, we also have certain additional application, which you can see called high definition imaging. Instead of improving the image at a particular area, but at multiple limitation, we now have this is called high definition image as well. So these are some of the technology which is incorporated in our current Resona series, and I9 is one of them. And this is one of the equipment which will be used in multi-center study as well. And obviously with this technology now we have a process called ultrawide beam tracking, which gives a better definition towards the penetration, and also it gives a better frame rate as well, which is almost 10 times the current frame rate of an ultrasound, shear wave elastography based out of ultrasound. So it gives a better penetration, it gives a better sensitivity, and also we have two important quality control features called reliability map as well as motion stability index, which ensures every time for every patient you have absolute accuracy. These are the fundamental aspects that improves not only the frame rate but also the accuracy, which improves in fact the repeatability of the results. This is one of the reasons we have at multiple locations these Resona-like machines available in the North America as well. These are some of the hospitals where they're using it. So this is my general presentation in a very, very short time. Based on this time limitation, I covered it a bit faster. Thank you so much for your time, Dr. Rijo, and thank you all for this opportunity as well. And have a nice program following this. Thank you.
Thank you, Mr. Agamparam.
Yes.
Technological advances have always been helpful for better applications in medicine. Thank you. And now we will move on to the next stop. When we planned this, Dr. Sharad Maheswari is also a member of the National Preventive Radiology Committee of IRIA. So when we planned with Sharad said it is essential for all radiologists when we speak about fatty liver and non-alcoholic fatty liver disease. It's essential for radiologists to understand the clinical features, the diagnostic workup, not just limit themselves into ultrasound or radiological modalities or even just into a liver elastography. We have to get the clinician's perspective, we have to get the hepatologist or gastroenterologist perspective. And he has suggested Dr. Gaurav Mehta, one of the best in this field. He had his fellowship and was trained in Drexel University School of Medicine in USA in gastroenterology, hepatology, and transplant hepatology. Currently working as consultant at Kokilabhen, Dhirubhai, Ambani Hospital in Mumbai, along with Dr. Sharad Maheswari, who is also a consultant radiologist there in the same hospital. So Dr. Sharad also had his fellowship in abdominal imaging from Toronto. And I must say I was lucky and fortunate enough to share some of my some of my registrar days in Jeslok along with Sharad. I'm very proud to say that Dr. Sharad is now a very well-known abdominal imaging specialist, well-known nationally as well as internationally. So let me introduce Dr. Gaurav Mehta and Dr. Sharad Maheswari to take the academic proceedings forward. Over to you, Dr. Gaurav Mehta and Dr. Sharad Maheswari.
Thank you, Rijo, for the kind introduction. Good evening, all the panelists and dear colleagues. So without taking much time, we'll start the session. So this is the objective, what we are going to discuss today. Pathophysiology of fatty liver. What is the spectrum of fatty liver? What are the clinical presentations? Then we'll talk about imaging and management strategy. So the more than 50% thing would be by Dr. Gaurav. We specifically wanted more of clinical knowledge to our radiologist so that they can understand the entire process. So let's start with a case. This was a 73-year-old female who visited Dr. Gaurav. This case is from 2016. She had very non-specific complaints. She was obese, diabetes, hypertension, and had history of endometrial CA. So the initial ultrasound showed hepatomegaly and fatty liver. So Dr. Gaurav sent the patient to me for a CT scan. So on the scout image, you can see that this patient is obese. And when we saw the scanners to our shock, this patient had cirrhosis and also had a hypervascular lesion, which turned out to be HCC later on. So you can see this patient had surgery for endometrial CA. This patient is obese, hypertensive. So this is what is called as metabolic syndrome. And metabolic syndrome is a combination of obesity, high blood pressure, high triglycerides, altered lipid, and insulin resistance is the key factor. So from this, we'll move to Dr. Gaurav Mehta. So he will talk about the clinical features. He has to later on go. So little bit of management also he will discuss in the same presentation. The management part will be short, as we'll more focus on the pathophysiology and diagnostic features. So over to Dr. Gaurav.
All right. Thank you, everybody. Thank you, Sharad, for inviting me to give this talk. I'm a hepatologist. I mostly do liver disease, and I spend a lot of time here with Sharad. And over the last 8 years at this institute, we have seen a lot of liver disease. We're seeing how liver disease has evolved. You know, our diagnostic methods have evolved, have improved, and it keeps improving every day. And I will present some of the data about what fatty liver disease is, what's the overall prognosis, why we should be very, very worried about this disease. So just some basics. Non-alcoholic fatty liver disease is very, very common, one of the most commonest liver disease in Western countries, but this has changed. Now we see a lot of fatty liver even in our country. And I'll show you some data about our country, the prevalence of fatty liver in India. And it's not a simple disease. It encompasses the entire spectrum of fatty liver disease, from simple steatosis, which we have to remember has a benign outlook. And most patients with fatty liver disease will have a benign outlook, to steatohepatitis, which is called NASH. So it's very important to distinguish steatosis, which has a benign outlook, to NASH, which is basically fatty changes causing globular inflammation, portal inflammation. Basically, there is cellular death, necrosis, fibrosis, and over a period of a few decades, these patients can progress to frank cirrhosis and complications associated with it. So this is the natural history of fatty liver. What we see mostly is people can go from a state of normal liver to a steatotic liver and then again become normal. You know, patients exercise, diet every few years. And so this process keeps happening throughout their life, and they can live a full life without any problems. But there are some subset of patients, and I'll talk about risk factors shortly, where they can progress from simple steatosis to NASH, which involves inflammation, cell death, fibrosis, and which can eventually lead to cirrhosis and hepatocellular carcinoma. Now, a lot of patients who are NASH, if they get diagnosed early, can be reversed to either simple steatosis or normal liver, and this cycle can continue all throughout their life, and they can still live a normal life. But the whole point is we need to pick up these patients who have steatosis and then figure out which ones are the patients who have NASH to prevent cirrhosis and hepatocellular carcinoma from happening. And it is strongly associated with insulin resistance. And in fact, fatty liver is considered a hepatic manifestation of a metabolic syndrome. So this is what a typical biopsy would look for patients with just fatty liver, which is isolated steatosis. They're just fat globules, but there is not much in terms of inflammation in the portal triad. However, if you look at patients' biopsy with steatohepatitis or NASH, there is a lot of fibrosis, inflammation. You see a lot of neutrophils, lymphocytes in the portal triads. There's a lot of cell death, apoptosis, and it subsequently leads to fibrosis. So a biopsy really is a gold standard. Even now, a biopsy is a gold standard to determine whether a patient has NASH or NAFL. So what is the prevalence of fatty liver? So fatty liver is, again, too much fat in the liver. About 30% of adults have it. This is little old data. Now the new data suggests it's almost close to 35 to 40% of adults. Again, the data all depends on where you're screening these patients. It's very different in the urban and rural populations. What's more interesting is about 13% of children have fatty liver disease, and that's very, very important. I will show you a few slides why. NASH is fat plus significant liver injury. So about 3 to 4% of adults will progress to NASH. And I would say about 20 to 25% of these will then progress to further liver injury, cirrhosis, which is a very large number of patients. Again, it depends on your weight. So if you're obese, the incidence of NASH is about 20% in some studies. They have looked at patients with bariatric surgery who have been biopsied in various studies, and close to about 25 to 70%, depending on the study you look at, will have NASH. So again, obesity is one of the central driving forces in patients who you should think about NASH and not just fatty liver disease. So this study was done by late Dr. Amrapurkar. He looked at the prevalence of fatty liver in Asia, and he specifically worked on the Indian population, and it's about 30 to 32%. So 32% of Indians have fatty liver. I think this data is almost 10, 12 years old now, and the incidence is much higher, but much lower in the rural population because obesity and westernized way of living is much less. However, if you look at other countries like Singapore, Malaysia, the incidence is much less because most of these patients are quite lean, and obesity has not really been an epidemic in these countries. So Indian data is roughly about 32%. So what is the relationship to obesity? So this is what I look at when a patient comes to my OPD, whether they're obese or not. So if they're obese, the risk of having steatohepatitis is much higher, about 20%. If they're morbidly obese, it's almost 50%. So if you have a morbidly obese patient, you're almost sure to have fatty liver, and there's a 50% chance that they'll have NASH. And a lot of these patients can have progressive liver injury. So whenever I see a patient in the OPD, the first thing that goes in my mind is, what is the prognosis of this patient? How do I follow this patient? Do I need to follow? Do I send them back to their general physician who has referred this patient to me? And these are 4 things that I straight away look at. The age. Age more than 45. Are they obese? What is the AST-ALT ratio? And do they have diabetes? The more the risk factors, the higher risk of them having fibrosis or severe fibrosis. So these things I look at. If they're younger, they're not obese, I tend to just do an ultrasound and follow them maybe on a yearly basis with an LFT. If they have risk factors, then I really want to know whether they have NASH. How about children? It is very common in children. About 10 to 15% of children have fatty liver. It's much more now. We've seen an exponential rise in fatty liver disease and NASH in children post-COVID. Patients are being seen by pediatricians. They are all overweight, gain significant weight. And in fact, the American Association of Physicians recommends that we do liver enzyme testing, both AST, ALT in obese children who fall above the 95th percentile, even in the absence of risk factors, because a lot of the children will have elevated liver enzymes and have NASH. So it's really an epidemic in children too. And why is it important in children? Because the prognosis is different. And this does not happen in adults. If you have just benign fatty liver, just fat in your liver, and you follow children's out, this is a very long study, over 20 years, where they followed 66 children with fatty liver, and they found the expected survival was less in patients who have fat. And I'm not talking about NASH, I'm talking about just fat in the liver. This is not true for adults. In adults, if you have fatty liver, it's a benign course if you don't have fibrosis. I have fatty liver. I get my Fibroscan done every 3 years. I just have fat, but no inflammation. My liver enzymes are normal. So I'll probably follow this course. However, if you have NASH, which involves inflammation, your overall prognosis is less compared to people without fat. Transplant. Dr. Mathew did speak about his experience in his city, and that's true over here too. I would say in our hospital, we've done close to about 300 transplants. I would say about 50% of them are for fatty liver. So it is exponentially rising, and the other diseases are sort of plateauing or coming down. So again, we will see most patients all over the world being transplanted for NASH now. So what are the markers of the chronic liver disease? Like, how do we determine whether this patient is going to have liver disease or not? So obviously we can do a clinical exam, but that's typically very late. We have a good clinical exam of ascites, splenomegaly when it's already too late for us to intervene. Biologic workup is always done to make sure there is no other cause of fatty liver. Liver biopsy is very, very helpful to diagnose. Again, it is still the gold standard to diagnose NASH. And if you look at most studies, they all depend on liver biopsy to make a final diagnosis. Imaging is helpful, ultrasound, MRI, endoscopy when it is very late, when you screen for varices and portal hypertension. Liver elastography with Fibroscan is what we do a lot over here. I mean, we have a unit which does a lot of Fibroscans. We have a big liver unit, so we do a lot of these scans. It does helps us in not only determining fibrosis, but also steatosis. There are blood markers which are available. Basically, these are simple blood tests where they look at multiple parameters and they come up with a score, and the score tells you whether this patient is at like a risk to get fibrosis or not. And obviously hepatic wedge pressures, but these are typically when it's very late. So we basically want to catch patients very early, use imaging modalities, liver fibroscan, blood testing to figure out which patients are the ones who will have fibrosis and progress to steatosis. Here's where the ultrasound MRI is very, very useful to change basically the overall prognosis of the patient. This is what I do in my OPD. Basically, this is a very simple online calculator. You can just download it on your phone. It's an app. I put these parameters, age, BMI, whether they have impaired glucose fasting diabetes, the liver numbers, platelets, albumin, and then we click this score. And it tells us a score which determines whether the patient has absence of fibrosis or presence of significant fibrosis. So if the patient has a very low score, I typically don't send them for any, I don't even do a Fibroscan. I just watch them because this score is very, almost like 90% sensitive. However, if they have significant fibrosis or if my score is indeterminate, I then go on to either a Fibroscan or an MRI, depending on what I am looking at. Dr. Sharad will obviously speak about imaging. Just a quick thing about ultrasound. It is useful test. Again, it's almost become like a screening test nowadays. We have other non-invasive tests in our hospital, like an MR elastography. You can do hepatic CT, MR spectroscopy to quantify microvascular steatosis. I will leave this talk to Dr. Sharad. Just a quick interesting thing. Ultrasound is obviously a test that patients mostly have done before they come and see me. But this is a very interesting study where they looked at the sensitivity of imaging. So these are all patients who had biopsies done and they have biopsy proven fat, steatosis by histology. So patients can have almost 30% of fat in the liver, but still there's a 20% chance the ultrasound will miss it. And patient with 10 to 20%, there's almost 50% chance that you may miss the fat. So it can be again, it is operator dependent. You have to do more and more to make sure you know and know when to report fatty liver. I do feel sometimes we over-report it a lot now, but I'm sure there's a lot of under-reporting too of steatosis. So I've had patients who have liver tests abnormal, the liver ultrasound is normal, but I have a strong suspicion that this patient has fatty liver. I go out with the Fibroscan and it shows significant steatosis. So ultrasound is a good test, but not the best. This is what I do a lot. We do a Fibroscan. We procured our Fibroscan about 6-7 years ago. We had a big transplant program, and really this was something that initially was approved in the US for hepatitis C to detect fibrosis. And the insurance companies in the US would only pay for the drug if you have F2, F3 fibrosis. And then we found multiple use of this device. It's transient elastography that evaluates liver stiffness using a pulse echo ultrasound. It's non-invasive. The good part, it evaluates a large part of the liver, about 5 centimeters. We have different probe size. It might be unreliable in the obese, but we do have an extra large probe. However, saying that, patients who have morbid obesity, this test is not good. This is what it typically looks like. It has an integrated computer with the acquisition software. It stores all my exams from all these years, where I can follow these exams. It has dedicated electronics with an ultrasound, shear wave generation, signal processing. It's a very, very simple device for a hepatologist to use. This is what the probe typically looks like. The probe size depends on, so this is a medium probe. You can have a large, extra large probe for obese patient with a larger surface area. I'll show you a few examples. Basically, it generates a score called the kilopascals, KPA score. The higher the score, the higher the stiffness, the more fibrosis, cirrhosis. The lower the score, the softer the liver, no fibrosis. So basically, this is what the report looks like. I'll show you some reports and some cases as well. Basically, it looks at the depth of the shear wave. If it's a soft liver, just imagine it's going quite deep and then coming back. If it's a stiff liver, it goes in quickly and comes out, and it generates a score called the KPA value. So this is a normal liver at 3 KPA. 9 has basically, depending on the disease, F2 fibrosis. Anything more than 14, 15 for fatty liver is cirrhosis. So this 40 basically is a cirrhotic liver. The more fibrosis in the liver, the higher the stiffness will be. One thing I would point is the KPA values are not the same as the ones you get in MRI. MRI has a different scoring system. It uses the KPA value, but the scoring system is very different, and Dr. Sharad will talk about it. So once we have the score, we put this on this card and see where the patient is. What's interesting is it is very, very good for fatty liver disease. If you can see the spectrum of colors, they're very close to each other. So once you cross this 13, 14 mark, you know the patient has F4, cirrhosis. It's not very good for alcoholic liver disease because a lot of inflammation will falsely elevate the KPA value. It's not very good for chronic cholestatic liver disease like primary biliary cirrhosis. It's very good for hepatitis C, hepatitis B, when you don't have an active infection. So any active infection, inflammation, such as alcoholic liver disease, acute hepatitis B, where the liver enzymes are high, this is not a good test. What it is very good for is fatty liver, hepatitis B, and hepatitis C. The other thing that our machine tells us is something called the CAP score, computed attenuated parameter, which basically is the amount of steatosis. So not only do I want to know fibrosis, but I want to know the amount of fat, because that's something I can follow on treatment. And it gives us a score anywhere from 150 to 400. And basically it correlates with the amount of fat. S0 is about less than 10% fat. S1 is about 33%, S2 up to 66. And if your value is above 290, it is S3, more than 67% fat. So patients can have no fibrosis, have significant amount of fat. And this is something that I treat. Patient have weight loss. We can follow this in a yearly basis and document the reduction in steatosis. So that's interesting, why Fibroscan is so helpful. This is a CT scan that Sharad had done on a patient with diabetes, recurrent UTIs, kidney stones, and was a non-contrast CT. And if you look at the CT, the liver looks fine, looks maybe a little enlarged, spleen is borderline enlarged, there are no varices that we see anywhere. And the patient was basically sent out that, you have a kidney stone. And Sharad mentioned on the report that there is severe fatty liver. And our urologist sent the patient to us for evaluation, and we did a Fibroscan, and the score was 42, which is cirrhosis. So this patient has had no manifestation of cirrhosis. Liver tests were mildly abnormal, normal platelet count, normal IRA, normal albumin, but he is frankly cirrhotic, even before the anatomy has changed. So this patient had a CAP score, which I talked about, 400, full of fat, and already has cirrhosis. So this is something that we picked up. This patient probably will lose the fat over the next 3 to 4 years, develop a complication maybe in 5 years. You could have an HCC anytime now. So again, very important test. Looking at the scan, doing a Fibroscan, diagnosing cirrhosis, fibrosis to treat these patients. So I'll show you a few simple report. This is how we report in our center. Every center is a little different. We do about 10 readings. Our goal is to have the IQR less than 10% to know that we are accurate. It gives us two numbers, fat and fibrosis. Again, 4.0 is no fibrosis, 320 is S3 fat, so about 66% is fat. So this patient basically was obese, ultrasound showed fatty liver, no other medical problems, LFT is normal. This patient most likely will have a benign course. He just has fat in the liver, no fibrosis. This is a very interesting patient. She basically, her grandmother had liver cirrhosis. Her father had liver cirrhosis from NASH and underwent a transplant with us. And one day she comes to see me with a report of fatty liver. And we do a Fibroscan. This is a young female. She's probably in her 30s. We do a Fibroscan. She has 7.7 kPa value. So she's already F1, F2 fibrosis, significant fat. We intervened in this lady to prevent a transplant from happening. Her grandmother died of cirrhosis. Father has NASH cirrhosis, undergone a transplant. And this young girl we evaluated. So basically, this is preventive radiology. We did an ultrasound, did a Fibroscan, we are preventing a liver transplant. This was a young boy, basically not exercising. His weight was about 85, 5 feet, 8 inches tall, eating a lot of junk food. His mother does basic blood testing, very, very affluent family, significant fat, again, F2 fibrosis. So he disappears and comes back to see me exactly after 1 year, with losing about 10 to 12 kilos of weight. The fat is almost gone. His fibrosis has reversed. So basically he's healed himself just by weight loss, which is the cornerstone of treatment. One last slide. This is my father's friend. He is quite morbidly obese, diabetic, did a health checkup, shows fatty liver, liver tests are normal. We do a Fibroscan and he has 11.3 kp. He's almost F3, F4 fibrosis. Very poorly controlled diabetes, very obese. We referred him for bariatric surgery. And post-bariatric, I don't have the report here, but this was in 2016. He's lost about 25 kilos. His diabetes is gone. He's not on any medications now. And his fibrosis is non-existent over a period of 3 to 4 years. So a quick slide on pathogenesis, because most of the drugs are made based on this. So to make it simple, you have to concentrate on one thing, liver-free fatty acids. If there are a lot of floating liver-free fatty acids in the body, they are the ones that lead to hepatocellular injury, inflammation. Where do we get free fatty acids from? Things we eat, things we drink. So carbohydrates and fats. So eating a very high fatty meal will cause production of chylomicron triglycerides, which again converted to free fatty acids and lead to this free fatty acid pool. Drinks, having Coke, high sugar, high fructose drinks gets converted to liver-free fatty acids for storage, which is extra energy basically. And these liver-free fatty acids can get converted to triglycerides, then you get hypertriglyceridemia. They get stored in the liver, with steatosis, leading to more free fatty acids, which again lead to hepatocellular injury, inflammation, which can cause NASH, fibrosis, HCC. But this is not the only mechanism. There are multiple other mechanisms by which you get hepatocellular injury. We've seen patients with obstructive sleep apnea, gut microbiome plays a big role, high uric acid, cholesterol. So it's not just one thing, multiple things lead to hepatic injury. But the cornerstone of problems lies with free fatty acids from high carbohydrates, high fat diets. So when we look at drugs, they look at two things. Either we make a drug which changes the response to injury, reduces fibrosis, or you make a drug which changes the way we metabolize the free fatty acids. The last and the most important thing is energy intake and disposal. This is in our hand. How much we eat, how much we drink, how much we exercise, which actually forms the major chunk of treatment. Drugs don't have a big role to play except for a few new drugs on the market, which I'll talk about. So when a patient comes to me, what do we start off with? Obviously, they see a dietitian, eating healthy, eliminate sugar, sweetened beverages, reduce carbohydrates in general. There's a very big misconception. Most patients, when I say they have fatty liver fibrosis, their first thing is, oh, but we are vegetarian. My pet talk is vegetarianism is a risk factor for fatty liver because you're eating less proteins until your diet is good. Most vegetarians are consuming fat and carbohydrates all day long. Use healthy oils, avoid saturated fats. Portion control is the key. And next thing I talk about is physical activity. Do things that get you out of breath. Sweat on a regular basis. When you say this to a 40-year-old, the first thing he does, well, I walk half an hour a day. That's not enough. You have to get shorter breath. Your heart rate has to go up. You need to do a mix of aerobic strength training. The more muscles you have, the more fat you'll burn. Walking is okay for those who don't do anything, but it cannot be the final goal. Just walking will never get you there. So weight loss is the key. This is an excellent study based on MRI, where they looked at patients who lost weight. If you lose about 10% of your body weight, 97% of patients had complete resolution of fat in the liver. If you lose 5%, 50%. So I tell the patients, be realistic. Most of these are like 80, 90 kilos. I said, lose 5 kilos and come to me in 6 months. That's about not even a kilo a month. So give them realistic goals, because if you lose 10% of body weight, your disease will stop. Basically, you'll reverse your disease completely. Bariatric surgery for very selected patients, as I talked about. There are post-op complications you patients need to understand. I just don't do it for fibrosis. If they have fibrosis with diabetes, then we push them towards bariatric surgery. Always vaccinate them for hepatitis A and B. Vitamin D deficiency is very, very common in these patients. Diagnose and treat sleep apnea. Sleep apnea is a risk factor for fatty liver. Limit alcohol. They can have a drink on the weekends. Statins are okay to use. In fact, they are very good to use in patients with high triglycerides or high lipids. It helps reduces the fat. And keep paracetamol, crocin used to not more than 2 grams a day. But the problem with lifestyle modification is not universally successful. So again, this is a very interesting scan where this is all images from Sharad and his huge library that he has. This is loss of fat following bariatric surgery. The patient had a scan done which showed severe fat, and subsequently had an MRI, and there's absolutely on the out phase no fat left in the liver. So bariatric surgery does work. This is a patient who wanted to donate liver to his family. They did a CT scan and found an LAI score of 2. He lost weight. LAI score became +10. He could donate. So weight loss is the key. He's not lost a lot of subcutaneous fat, but the visceral fat is sort of gone. So what are the guidelines? This is the American Association guidelines for treating fatty liver. Metformin was initially thought to be helpful, but is not recommended for treating NASH. It has no good benefit. Pioglitazone can be used in patients with or without diabetes. The only risk of pioglitazone is it can cause some weight gain and fluid retention. So it should be really carefully used. I personally would not write for pioglitazone. If the patient is diabetic, I'll let the diabetologist write it. Again, the other thing that would bring it is this fatty liver disease is actually a multidisciplinary team. The radiologist helps us. We use a lot of our endocrinologists to help treat this disease. Vitamin E was actually a game changer about 12 years ago when I was finishing up my training. This was initially made by Dr. Arun Sanyal, a big study from University of Pennsylvania, where they gave patients 800 units of vitamin E in non-diabetics, and they found a significant reduction in inflammation fibrosis based on biopsy. It was not recommended for NASH in diabetes just because the patient in that study did not have it, but we have used it over the period of 5 to 6 years liberally in patients with diabetes, and it has really helped a lot of our patients like an antioxidant. So the minimum duration is about 2 years. There are multiple drugs in trial. These are the top 5 drugs which are in trial. There are about 120 drugs if you look at the clinicaldrugtrials.gov for fatty liver. The only drug that has been approved in India is saroglitazone, and we'll talk a little bit about it. It's a PPAR agonist. Basically, it's like a statin on steroid. It's almost 1,000 times potent than a fenofibrate. And there's excellent data behind it. And we have been using this drug for about a year and a half, and I have had excellent results with it. So it's a dual PPAR agonist. It works by reducing hepatic inflammation, reduces hepatic steatosis, reduces VLDL secretions, it reduces triglycerides rapidly, and it also reduces fibrosis in the liver. So it's a drug which not only reduces triglycerides, fatty inflammation and accumulation, but also reverses fibrosis based on the biopsies. So it's a very, very important drug in our armamentarium. So in conclusion, NASH, I think, is going to be the next epidemic, if it's not already here, from chronic liver diseases. Diagnosis remains a challenge in practice as biopsy is not always feasible. We do use a lot of non-invasive tests to stratify patients in my mind and my OPD. So which are the patients I need to follow, which are the ones I'll get in trouble. Lifestyle modification is a cornerstone, but I'm telling you, if I talk lifestyle modifications, I would say about 10% patients do it. 90% would rather have the drug, which is quite sad. Currently, only saroglitazone is approved for the management of NASH in India by virtue of resolution of NASH without worsening fibrosis. It is a drug that now has been around for a year and a half. It will soon be approved in the US as well. It is a game changer for fatty liver. Patients' triglycerides improve dramatically within weeks. and you see reduction of fat, fibrosis at 6 months, we would repeat a Fibroscan, and they have already a 1 to 2 drop in the KPA value. So a really, really very helpful drug. But again, all this is possible if we screen patients early. Sharad is very proactive. Every time he sees a patient with fat in the liver, he gets excited, calls us, we see the patient. Working in a closed environment over here, there's a lot of inpatient references. So there's a lot of education in our hospital about fatty liver. The clinicians are very sensitive to this, and they quickly make references to try and catch these patients again. And I think preventive radiology for this is the only way to do it. I think drugs have a role, but a small percentage of it. I think if you prevent this disease from happening to begin with, it'll probably be more helpful. Thank you for your time.
Thank you, Dr. Gaurav. That was a fantastic presentation. I hope my radiology colleagues would have learned a lot from this. And this is what I wanted, since you're talking of preventive radiology, means something which has not been apparent. So we need to know what is all happening in the background, what is the thought process going in your mind of your gastroenterologist. So you'll be better able to interact. So what we do here, the moment I see fat, I make a note in the impression that there is fatty liver. And if I think this is little more concerning, then I even write in my report that gastroenterology consultation is suggested. So this way it is helping. So Rijo, Dr. Gaurav has to go out for some social obligation. So we can take few questions from the audience for Dr. Gaurav.
I think we've not received any questions right now, but I think Dr. Gaurav has presented the larger perspective, the perspectives that radiologists currently are not much aware about, but how Gaurav has given a lot of hope on the treatment of saroglitazar. So do you think that this is the future of we will be able to make a qualitative and quantitative difference in NASH with this particular medicine, or this is just a experimental phase of?
No, the data is very, very strong. I mean, the data initially came from US, Europe, and then we did our own studies over here in India, and it showed significant improvement in steatosis, steatohepatitis. I would say about 40 to 50% patients respond with this drug. But saying that, it's just a drug. I mean, like any other drug, drugs are very rarely game changer. It's a whole thing. This patient needs to do exercise, need to lose their weight. But we've had remarkable improvement in fibrosis and steatosis in patients who are not exercising at all. The weight remains the same. But if you look at the blood test, look at the triglycerides, look at the oral parameters, for me, as of now, this drug is a game changer and the problem is we don't have anything else. We don't have anything else in the pipeline. There are a few drugs that are coming up, but nothing has been approved so far. It's going to take several years before we get any other drug. And it's quite a benign drug. It's much more safer than a statin, but almost 1,000 times potent. So it's good to give in patients who are, even those who are this pre-diabetics, where the HbA1c is 6.2, I would give this. It reduces the HbA1c by a few points. Those who have high triglycerides, we give it, reduces the triglycerides significantly. Overall, I think for me, as of now, this is a game changer.
Yeah. So regarding the glycosylated hemoglobin, whenever I see fatty liver and I see some fat in the pancreas also, which I would suggest radiologists to look at the pancreas also. And so many times I have asked for a glycosylated hemoglobin, and though they were not like over diabetic, but their glycosylated hemoglobin was on the higher side. So I think glucose intolerance, insulin resistance is a very important factor.
Right. I think that is, I think we have to look at all these things, especially for the Indian population. The cutoffs are changing. Even the BMI has changed now. That 223.1 is a new cutoff that for Indian population. So it seems that maybe the insulin resistance factor and imaging biomarkers like fat in the pancreas, also has to be taken into consideration. So there are a lot of things that we may have to consider for our population with respect to imaging biomarkers. This is one area that I was discussing with Sharad earlier, that when we do a diagnostic workup for any other disease, we tend to see a lot of early imaging biomarkers that can be that can have a lot of clinical significance. That is how we thought that even this preventive radiology concept has to be strengthened with such pickups. Like what Sharad said here, fat in the pancreas is often ignored by the clinicians. 20 or 30 years back, when most of the radiologists doing ultrasound reported fatty liver, increased fatty liver, that was not being taken seriously. So the radiologists are in a position with to come out with some early imaging biomarkers, and that is one of the core focus areas that preventive radiology intends to do.
No,
so thank you, Doctor.
Absolutely. I think even in our hospital, you have a big health checkup department, and like every hospital does now. And they are the driving force. I'm telling you, the ultrasound department over here is the driving force. I would say 50 to 70% of my patients have come through radiology. And you'll be surprised as to the amount of liver disease we pick up. And we talk about it. It's almost scary actually at this point. Yeah. Thank you.
Thank you, Dr. Gaurav. Wonderful presentation. And we wish to see you again in our forums with this multicentric studies. We would like to get inputs from your studies also. One more thing, before you leave, 2D shear wave elastography is coming up in a big way. So what are your impressions in comparison with Fibroscan, MR elastography, and 2D shear wave?
No, that's a very interesting point. We don't do a lot of 2D shear here. We have it. I know we have it. So a couple of our ultrasonographers do it. For some reason, I have not developed confidence in that study. Whenever I get reports, I get reports of KPA value which go from anywhere from F1 to F3, and then we compare it to our elastography, and somehow I find Fibroscan to be much better. And I am biased, but personally, I feel MR elastography is the best test. And I think we are also comparing, we're going to be doing some study where we'll compare Fibroscans to MR elastography. I think I'm just biased because I don't see a lot of shear wave here. And whatever reports I get from some of my patients, I'm not happy with the quality of the report. Where there are areas where they're calling it as F1, there are areas where they're calling it as F4. We know it can be a patchy disease, but it cannot be F1 and F4. It has to be somewhere sort of. That's where the Fibroscan is so helpful, because it gives you an interquartile ratio, and you have to have it below 10 to make sure the report is valid. So one of the things is who's doing it, and is the report a valid report? Because we see a lot of times patients come with a report and we repeat it over here and there is no fibrosis. So I think I'm a little bit biased towards what I have, but as the other gentleman was saying, with his new ultrasound, it'll shed much more light. And you're doing a study.
Yeah, I think what you said is right. There has been a little bit of during the development of 2D shear wave, between the vendors, and there has been a significant variations and the technologies that were used. Now that we are seeing a little bit of stabilization with a lot of quality parameters now being added, the interquartile bar median, and the mobility, motion stability index, and the reliability index. A lot of quality parameters are now coming into use, and I feel now this 2D shear wave is getting stabilized. And with the kind of multicentric studies that we are doing for Asian Indian population, I think we will be in a position to tell how effective and this in terms of in comparison with the Fibroscan as well as with MR elastography.
And I get
this is a much wider.
Yeah, sorry.
Yeah. Tell me, please.
No, I agree. I think you're right in what you're saying, because we're using this for preventive radiology, and anything preventive, has to be cheap and reproducible. Fibroscan is not cheap. The machine is not cheap. It's not a cheap test to do. MR elastography is not cheap. So anything that you use preventive for any disease, it has to be cheap, easily reproducible, and available to the masses. So I think shear wave is the only thing that will be sort of fitting all these three criteria.
Thank you, Dr. Gaurav.
Doctor, I just want to have one remark, if you don't mind, before Dr.
Yeah,
Gaurav
please.
leaves. I think this was also the statement made during the last presentation we had with the radiologist of Jeslok as well as Dr. Nitin Chaubal. And Dr. Nitin Chaubal very confidently stated, with the current new technology available, you can have a comparable study even as compared to MR elastography as well. And it has improved the reproducibility and repeatability with the new technology. This is, I think that's something, we can relook at it. We would be very happy to come and share this technology as well with you.
Absolutely. Thank you.
Thank you, Doctor.
Sharad, you can take over.
Yeah. So thank you, Dr. Gaurav. Bye. So some of which we have already done. So the objective of my presentation would be to know all these points, like what is fatty liver disease, what can it do to the liver, where does it lead to, and what is our role as a radiologist here. So what is fatty liver? Actually fat globules accumulate within the hepatocyte. So this is a fat lobule within the hepatocyte. That's the nucleoli which is not disturbed. So this is called as microvesicular fat because it's a small fat lobule. But when the fat lobule becomes big, it causes displacement of the nucleoli. And just imagine in a cell, there's a lot of things. There are mitochondria. So there's a scaffold inside the hepatocyte. A lot of structures are there. Now, when the fat starts taking a lot of place in the cell, it disturbs the cytoskeleton within these cells. So this is where inflammation and all other problems start happening. So when there is only fat, it is NAFLD, non-alcoholic fatty liver disease. But when there is cytoskeletal injury, inflammation sets in. So then we have a state which is called as NASH. Now, when you call NASH, these three features should be there. One, steatosis, that is fat. Second is inflammation. And third is ballooning, when the cell starts distorting because the inside skeletal framework is all disturbed. And this is what fibrosis staging is on pathology, which is called as Meta grading system. And this is what we follow for our results. So if you have to compare, so we compare with the Meta grading system. So F0 is when there is no fibrosis. F1 is when there is a very minimal fibrosis. F2 is when the fibrosis spreads from one cell to other cells. So it has gone out. But if you see the portal triads, the vessels, they are not affected there. But gradually these fibrosis becomes crisscross. And then, the distortion of the morphological structure starts happening. And gradually the normal liver is distorted, destroyed. And what we see in the intervening liver between the fibrotic bands is the regenerative nodule, which we see on CT and MR. So you must have seen very bad liver, which are studied by hypodensities in the CT or hypointense nodules on the MR. So this is nothing but distorted, destroyed liver parenchyma between the fibrotic bands. So this is what we are. We are the gatekeepers, and we are the first one who will detect it. And we are the first one who will sensitize the patient also. Not just will write on the report. We have to tell the patient also that you have fatty liver, and you may tell a little bit about it. And if you think the fat is much more like moderate or something, then you should even suggest to seeing a physician. So first thing is identify the fat, which we all do. The next we can do is to quantify the fat. So how do we quantify? So ultrasound is more of qualitative. This is the normal liver and this is fatty liver. And as Gaurav was telling you, obese patients are those patients you see more with fat. So enlarged liver, obese patient, and lot of fat reduces the visibility. CT scan is a very simple test. It is done. It is the investigation of choice for most of the transplant centers because it is fast, quick. A plain CT of the upper abdomen, no fasting required. What you do is you measure HU values. You take 5 ROIs at one level in the liver. You avoid the vessels. So similarly, you take at 5 levels. Spleen 3 into 3. So total we get 25 ROIs on liver, 9 in the spleen. And then you create a mean of that. And mean liver HU minus spleen HU will give you the liver attenuation index. So anything above +5 is normal. So what is the definition of significant fat? So these HU values I'm talking is at 120 kV because more and more now the scans are done at lower kVp because of radiation concern. So whenever we are doing a scan for fat quantification, we do it at 120 kV. So if you measure the HU value on the liver and if it is less than 40, so regardless of the HU value of spleen, that liver has significant fat. If the liver attenuation index is less than -10, so meaning the liver mean HU value is less than 10 compared to spleen, then it is significant fat. And similarly, you can create a liver spleen attenuation ratio also, but all the transplant surgeons go by the liver attenuation index. The MR is more accurate, but this is a quick investigation. So MR is basically chemical shift imaging where you do in phase and out phase. Now let's look here at the microscopic level. That's a hepatocyte. This is the fat and that's fluid. So the in phase, the fat and water signal add to each other. So look here on this T1 weighted image, the liver looks bright. Now, when they are precessing against, when they are on the out phase, they are signaling against each other. So what happens is there is a signal drop. So here the signal is adding, here the signal is subtracting. And now we do a Dixon. Everybody does it. It's very popular. So what you get is a in phase, the out phase. This is the fat image. So when there is no fat, the fat image is dark. So that is, and then you have the water image where the fat has been subtracted. So there is a formula by which you create the fat percentage. But there are certain problems with the Dixon sequence, so which we call as confounding factors. The fat quantification by Dixon is not accurate. Why it is not accurate? Because the fat proteins and the water proteins, they're not able to accurately separate. Then there is something called as T1 bias. Now, the relaxation times, T1 relaxation time of water and fat are different. So that's why a low flip angle sequence is done to remove this bias. Then you have a T2 star decay where the MR signal shows decay, but then when there is iron deposition in the liver, this decay is much prominent, and then you don't get a proper fat quantification. Secondly, fat is not just a single peak. It is a multi-peak, and what we see is like on a when you do a simple MR in phase, out phase, you are not able to catch all these peaks. So then we use a sequence which is called as proton density fat fraction, PDFF. It is nothing but Dixon only, but there are more T's used. So I'll show you that slide also later. So here the proton density fat fraction identifies the fat protons and identifies water protons. So it is accurate quantification. So corrected fat divided by fat plus water signal. So it is considered PDFF. Mark this, that it is considered as a MR biomarker or of hepatic steatosis. It has been validated, it is accurate, it is precise, and it is reproducible. So for fat quantification, we use PDFF. So PDFF is nothing but it's a multi-echo Dixon. The standard in phase and out phase, what we do, we use 2 echo times, but here they're using 6 echo times. And it's very easy. Once the sequence is done properly, you get this chart where the upper one is about the fat, the lower one tells you about the iron. So you have a marker there. So just by color also you can say normal, mild fat or significant fat. Otherwise it gives you a fat percentage. Now MR spectroscopy is a reference standard for PDFF. It has been there for a long time, but the problem was MR spectroscopy was you would place a single voxel. So if I have to quantify the fat, I'll have to do spectroscopy multiple times. So on a PDFF sequence, it is just one-time sequence, and then you can generate as many ROIs as you want. Or on a PDFF, you can map the entire liver in one ROI. So MR spectroscopy would be ideal, but it's not practical. So then we use PDFF, which is easy to do, and you can post-process it. So on a normal, say we are doing a liver and there is fat, so we do a PDFF. But if there is a patient who has come specifically for fat quantification or it's a liver donor, then we confirm the PDFF findings by MR spectroscopy. And 99% times the PDF findings are similar. So as Rijo was talking and Dr. Gaurav also said that there is a long window before cirrhosis happens. So we need to also detect early signs of chronic liver disease. Since we are doing MR elastography for such a long time, there are so many times we are ourselves surprised. The liver margins, though liver looks little abnormal in terms of caudate lobe enlargement, but the liver surface is still smooth and there is still a lot of fat, but they turn out to be advanced fibrosis. So is NASH cirrhosis little different from other cirrhosis? A little bit, yes. Just this I'm talking based on the experience, and there's some logic also too. So the NASH cirrhosis is a very slow process. the fat starts depositing, mild fat, moderate fat, severe fat, and then gradually fibrosis is happening. And as fat is depositing, inflammation is happening, there is hypertrophy. That hypertrophy is happening everywhere. The caudate lobe is enlarging, the left lobe is enlarging and crossing towards the spleen. The right lobe is pushing the diaphragm up, the right lobe is going down. So like I call it as a sumo liver. So it is taking up the space everywhere. And in advanced stages, the fat is lost. And then gradually you will have the classical appearance. But trust me, even before the classical appearance, we see on imaging, a lot of these patients already have fibrosis. So the liver may look very weird. Like here you see there is no nodularity, but then the surface is little lumpy, bumpy. This one is little advanced. You can see lobulated margins of the liver. The caudate lobe is enlarging. The fissures are becoming prominent. Still, for some, this may not look very cirrhotic, but this, when you do a volumetry, the surface look of the liver, see how lumpy, bumpy it is. This is an example of a normal liver. See how the anatomy is, fissures are not so prominent. And this is the surface display. This is a fatty liver, but you can see here, it is going up, it is going towards the left, it is going down, this is enlarging. So, and this is how the 3D look. 3D gives you much more striking appearance. So this was a patient, fatty liver, and in his first presentation, there was a hypervascular liver lesion. So like I have shown this patient who had a CT with us in 2012. This is a contrast image. The LAI was -15. Then this patient came to us in 2016. The LAI was +4. And when the patient came in 2017, there was no fat, and you can see the regenerating nodules, and the liver was already cirrhotic. So I have many examples like this. We have been following patients from 2010, 11. So a natural history, how the liver gradually becomes abnormal. So I had interest in fatty liver from start. So now we are able to detect, and we are able to refer patients even before the liver really looks abnormal, just based on some anatomical changes. Now you can have fatty liver from different reasons. This is post-chemotherapy. This is nutritional after Whipple's disease. This is alcoholic fatty liver disease. Now a lot of patients which are coming, since alcohol is now like socially also it's not acceptable. So we have a lot of patients who are diabetic and also have history of alcohol consumption. So that add fuels to the abnormality. And I've even seen patients who had hepatitis B also having alcohol and also diabetic. So not all fatty liver progress to cirrhosis, but when these extra factors add into, it progresses faster. Now, liver biopsy is gold standard to detect fibrosis, but it is invasive. You cannot apply for a large population. And Dr. Gaurav told you that the fibrosis is very heterogeneous. The entire liver does not become F4 fibrosis at the same time. So there are areas which are F2, there are areas of F3. So now it depends where the biopsy was done. So the biopsy just 1 in 50,000 of the liver volume. So the part of the liver which you got the biopsy may be just F1 fibrosis, or maybe it's a spared normal area. So shear wave elastography is the new biopsy. It is also the new age palpation. When the liver is firm and is palpable, surgeons and physicians, they can tell you that, oh, this liver is hard and this is probably cirrhosis. But when what if it's not palpable, it is not advanced, then elastography will show that. So not only it has a diagnostic value, it has a prognostic value also. Now, what is shear wave elastography? Let's look at this. Think of your physics from class 9. Whenever you apply pressure in a tissue, you induce a strain. The layers of the tissue change, move out, they shift outwards, the shape is changed. So this generates waves, and these waves represent the stiffness of the organ. So the shear, the velocity of this shear wave is a surrogate marker of fibrosis. So harder the liver, the faster is the velocity. This is just elastic, but the liver is viscoelastic. So there is fluid also and solid also. So our shock absorbers, they are viscoelastic. So this is water and this is oil. So see, when you put a stone in it, in the water, drop a stone, the ripples in water are very homogeneous, symmetrical, same wavelength of each wave. But when you drop a stone in oil, the wavelength is more and the uniformity is not there. So the liver elasticity depends on the parenchymal stiffness and the quantity of fibrous tissue. Now, when the fibrosis increases, parenchymal stiffness increases, the elasticity reduces. Now, stiffness increases apart from fibrosis, it can increase in inflammation. So if somebody is in acute hepatitis, then you will have wrong values. Biliary obstruction, congestion of the liver, say you are having congestive cardiac failure, infiltrative disease, lymphoma, sarcoidosis, metastasis. But important, simple fat does not affect the stiffness of the liver. So if it is pure fatty liver, then your results will be good. But if you add any of this thing, so results will be different. One more thing, when you do an MR elastography, it is good to have fasting of 4 to 6 hours, because when if you do it after having meal, there is increased portal flow to the liver, and that will not give you the right accurate values. Now, stiffness decreases with regenerating nodules if you have a normal parenchyma between abnormal and necrotic tumors. So how do you generate shear waves? By external mechanical vibration, which can be done by transient elastography, that is Fibroscan, or MR elastography, or in ultrasound, where you have focused beams of energy which are transmitted into the tissue of interest, and then you generate the shear waves. This is a comparison. So MR is highest accuracy, because the sound, the mechanical waves which are coming at one frequency, which is 60 hertz. Whereas I don't know about the newer technology, but when you do by ultrasound, the wave is polychromatic. So there is high variability. Between Fibroscan and MRE, Fibroscan is very good for high fibrosis. So when Gaurav does a Fibroscan and he finds F4 or F3 fibrosis, he doesn't send us for MRI. But whenever he has other shortcomings like a obese patient, or if Fibroscan is showing low fibrosis score, but his clinical thought process is like more confidence in having fibrosis at a higher grade, then he sends for MR. So even when we started, we didn't push him, don't do transient elastography, send MR to us. So similarly, what happened with MRCP, initially there was a lot of resistance from the gastroenterologists. They didn't wanted to send to patients for MRCP because they thought they will lose ERCP. But what happened, MRCP now generates more work for ERCP. So similarly, let them do transient elastography. It is quick, easy. They get the result immediately. But what we need is those patients where there are certain shortcomings in technology as well as other clinical features. So more transient elastography is happening, more MR elastography patients we get. I don't do myself, but this is two patients from our institute. This is a normal liver and this is cirrhotic liver. The Kp values are high. You can even see the liver is coarse, and there is color coding which is easily appreciable. So I think more and more shear wave elastography should be used by radiologists on their ultrasound machines. MR elastography, it has highest repeatability and reproducibility. It is the closest to biopsy as of now. There is no bias across the vendors. So the patient may have first elastography on a GE machine, and for the follow-up he comes to Siemens, it is fine, doesn't matter. If a patient had an elastography on a 1.5T machine, follow-up is coming to 3T, it doesn't matter. So as of now, MR elastography is the best technique. So you have a mechanical driver on the surface which sends the waves, and a motion sensitive sequence which is a gradient sequence. It detects the wave motion, shear waves, and then it generates a stiffness map. So red is high grade fibrosis. Blue and purple is normal. So this is a normal patient. This is an elastography cirrhosis patient. You can see the shear waves are lower wavelength and they are homogeneous. Here the wavelength has increased. This patient has fatty liver, 17% fat, insignificant fat, but there is no fibrosis here. This patient has a lot of fat, 30%, and on MR elastography, the Kpa values are on the higher side, which you can see on the color map tells you. So that is steatohepatitis. So this is a dangerous stage where intervention should take place. Now, as we said, liver fibrosis is very dynamic, very heterogeneous. So what earlier we used to do, we used to create multiple ROIs and we used to give a range. So there is a range of F2 to F4 fibrosis. But then next time when the patient comes for comparison, this map will completely change. Some other areas will be fibrotic, some may change. So what is done now is you create a ROI of the entire whatever liver you can. So anything between this checker mark is the accuracy is higher. So you create a large ROI draw and you take at least 4 levels in the liver and then you create a mean ROI. So this range may be so much in this patient, but I will create a mean out of this and then give a fibrosis score. So basically it gives you the fibrosis burden, while liver biopsy we don't know where it will happen. So if it happens in the right lobe, the results will be not accurate. I'll skip this slide. Now, there are times due to technical challenges, the MR elastography is not good. So only this much part of liver, I can give the ROIs with confidence. So should I reject this patient? No, because this is still better than biopsy. This is at least covering, say, 4 or 5% of liver, while biopsy would be 1 in 50,000. So see this patient, it has abnormal liver shape-wise, but see the surface they are homogeneous. Sorry, it is smooth. I don't see any nodules there. There is a lot of fat, 25%. And to our surprise, this was a F4 fibrosis. So, as I said earlier, believe me, even before the surface is nodular, people may be advanced fibrosis. This is a borderline diabetic patient who had a alcohol binge, came for the elastography. I was so excited. The liver is cirrhotic, called Gaurav. And Gaurav told me, no, the GGT is very high. So, so what is happening here? The entire liver is inflamed. So this value is wrong. And one more lesson I learned, again, I will reiterate, the liver fibrosis is a dynamic process and it is very heterogeneous. So you can't have a grade 4 fibrosis everywhere in the liver. So whenever I see this kind of image, I know that this may be a component of hepatitis or some problem. It's not the right result. So the take-home message, fat and early fibrosis is reversible. It diminishes the risk. It is very important to give accurate and precise quantification of liver fat, which can be reproduced, because that will guide the treatment. And currently, the best sequence to quantify fat is PDFF sequence on MR, and a best technique to detect fibrosis is MR elastography. But gradually things will change, I'm sure, with other technology developing it. Thank you.
Thank you, Dr. Sharad. That was Dr. Sharad Maheswari, the consultant and abdominal imaging specialist from Kokilabhen, Dhirubhai, Ambani Hospital, Mumbai. Sharad, you gave a wonderful insight into the various imaging modalities that are used in fatty liver. One of the points that you highlighted is, see, this is one point that I wanted to bring as part of the Preventive Radiology initiative, is as part of a diagnostic workup with all the imaging modalities, we often come across certain imaging biomarkers which we often ignore. One such biomarker, that is fat in the liver in a CT scan, is something many people may see, but Sharad has really highlighted that particular point and said, this is something that I always write in the report and even sensitize the patient. So what is your recommendation to our radiology colleagues who are doing CT when they see fat in the liver? Most of the time, sometimes somebody sometimes they just even don't report it. So what is your recommendation to them?
Yeah. So try to quantify the fat, mild, moderate, severe. When it is moderate, now you can look for the definitions, how to call moderate. And as I said, if I'm doing CT, you quickly have the LAI done. Now for transplant patients, we take 25 ROIs. For a regular imaging, it may not be possible. So take 3 or 4 ROIs and then create a mean. So if you think it is a moderate fat, I would straight away write gastroenterology consultation is suggested, because when I write fat, most of the say urologist or internist, gynecologist, they don't do anything about it. And I'll tell you interesting story that.
So Sharad, let me ask you, will you recommend a 2D shear wave elastography or a Fibroscan for such
No,
patients?
what I do, I don't recommend elastography. I say gastroenterology consultation because
So suppose if in your department you are having a shear wave elastography, and will it be possible to have a imaging algorithm worked up on such lines? That's what we have not yet explored such possibilities.
yeah, I think, but it also depends on the passion of the radiologist. So I'm not criticizing. Like we have 2D shear wave ultrasound. I personally didn't know because I'm not doing ultrasound. I stopped after 2014. So when I was making a presentation a few months back, so I wanted ultrasound images. So then I came to know we have shear wave elastography. But then it's about your passion. You are busy with a lot of things, so you may
No,
not.
Sharad, we have to see this in the larger perspective of a pan-India basis, where people have CT, people have access towards a 2D shear wave or a Fibroscan. In the tier 2 cities and below that, it may not be the metros alone I am talking about. So in that scenario, we have seen in CT a fatty liver, and will you recommend them to do advice for a 2D shear wave elastography? Because that can give a quantification of the fibrosis and can give a better assessment. Of course, gastro consultation, hepatology consultation, physician consultation, but in those places where the gastro or hepatology is not easily available, how can radiologists lead that investigation?
But I think if you are doing shear wave elastography, then you can look at the fibrosis there itself and put it on the report.
Yeah, right.
So I think that should be encouraged.
Yeah. So that's, say, Sharad, we have to see it from the pan-India perspective. 70 to 80% of Indian practices were maybe having CT or an ultrasound, and they may not have access towards MR, or even sometimes a hepatologist or a gastroenterologist may not be there. So radiologists in those places may be in a position to better quantify.
Yeah. And one more thing I add, LFT. So yes, suppose I don't want to write gastroenterologist because there are some referral physicians who don't like this, that you don't tell us whom to show. Then I will just write LFT correlation.
Yeah.
And I'll tell you interesting scenario. Lot of endometrial CA, ovarian CA patients are obese. Yeah. And when they come for pre-surgical scan, I call them, oh, there is a lot of fat. I think there may be fibrosis. I think this is early cirrhosis. So they're like this, I'm going to operate 2 days later and you are trying to tell me this. And we had where post-operatively patients have decompensated and they have become cirrhotic. And on retrospect, when we see the scan, oh, this was early feature which we did not think so much. So like a lot of 50% renal stone patients have fat. So in my report, I used to write ureteric calculus obstruction, fat, LFT correlation. So urologist called me. Like patients then like push us to do LFTs. I have to remove a ureteric stone. And so depending on the practice. So he said, then I said, no, but this is important. She said, just you write fatty liver and leave it for me. Don't tell me LFT and all that. So depending on your practice, how comfortable your physician is, you give some hint.
Yeah, I do understand the challenges, pragmatic or practical situations that of different entities of practice. I do understand. But another point that you highlighted in your talk, which also caught my attention, is the NASH cirrhosis is different from the alcoholic cirrhosis or the type of other cirrhosis that you come across, which has got even smoother margins and but early lobulations can be a marker.
Yeah.
So that is very interesting perspective that you have shared here.
So see, like here, I don't think anybody would call this cirrhosis, but I call them fancy names also, like sumo liver, lumpy bumpy liver. But this always looks to me like a dinosaur. So when I see a dinosaur like liver, so this just running imagination. I don't mean to say every time you see a liver, you think of this. So this is based on last 10 years, I've seen these patterns. So now that even if the surface is smooth, somehow if the patient is diabetic, I know that this is abnormal liver. So I flag it.
And I think it has got some significance and correlation with some of the clinical symptoms that these patients have. Maybe in terms of reflex or kind of symptoms or the sleep apneas, all these things causing fatty liver. So I think there is a larger area that has to be explored there. When you see in your diagnostic workup, either through a CT or MR, you see some morphological changes in the liver shape that can be part of the fatty liver disease or the NASH or a development of cirrhosis in an early stage. So these are the areas that we need to explore, which currently goes unnoticed, or we have not paid much attention to these kind of findings, on which Sharad has paid a lot of attention for the last 10 years and is doing.
So see, this liver, nobody will call this as cirrhosis.
Yeah.
Right. But when I see coronal, I find it abnormal. Now that liver is trying to go everywhere.
Yeah.
And then I do a 3D. Now everybody will say this is cirrhosis.
Yeah, true. Very salient points raised by Sharad. Sharad, third point that you highlighted in your talk, I just want to bring attention to that, is now that non-alcoholic fatty liver is one entity, even though it was described earlier, but there is a lot of overlap between alcohol, people who are taking alcohol, and fatty liver disease. So what are any specific findings that can help us to say, or how heterogeneous can this be?
So means this also my experience when I see a specific fatty liver. Now most of the so many times in the clinical notes, it never comes as alcoholic. Patients also don't want their doctors to write alcoholic, or the patients are admitted insurance problem.
Yeah.
And I've tried 9 out of 10 times. Whenever I see these nodular deposits, I call the gastroenterologist. I say, "Oh, is the patient alcoholic?" So and I studied a bit about it also. So what happens? Alcoholic patients, the cells burst and the fat gets deposited as a nodular fat. It comes out of the cells. It's not a proper research, just reading it. So in alcoholic liver disease, you get these nodular fat deposits. So that is one consistently I have noticed.
Okay. Very interesting finding that needs to be explored further. Yeah. So there can be, the why I asked this question is in Kerala, we see a very interesting pattern. Fatty liver is on the rise. There is no doubt about it. Non-alcoholic fatty liver but there is considerable overlap between alcoholic this thing also, and diabetes is also on the rise. So there can be a lot of different patterns that we may come across, yet we may not be able to categorize them in a particular entity. So these are the areas that the preventive radiology intends to explore with you have to observe it with your imaging modalities. And like Sharad has been doing for quite some years, that is one of the reasons why we wanted to bring Sharad into this preventive radiology OP today, because he has done significant work on this particular area at Kokilabhen Dhirubhai Ambani Hospital after his return from Toronto after his fellowship in abdominal imaging. So thank you, Sharad, for the wonderful insights that you have shared. And as part of our multicentric research studies, we are comparing, as I've already mentioned, comparing the diagnostic effectiveness of Fibroscan versus 2D shear wave elastography versus MR elastography versus biopsy in Asian Indian population. This is the IRIA study with which Mindray has partnered, and Mindray has shown interest to collect the Indian data, and that is why we are thankful and grateful to Mindray for this partnership. There are a few questions here I can see. How to quantify fatty infiltration of pancreas?
Okay, you can do by Dixon also, but I have not done it.
Okay. So probably this
because
is
unless there is some standardized thing, but I have made a point to write if I see fat in the pancreas, and so many patients I have seen when like health check patients who have these fat in the pancreas, then I go and check their glycosylated hemoglobin are on the higher side.
Yeah. Yeah, that is, Sharad, what you said is absolutely true. See, because in PCOD patients, we see this fat in pancreas considerably high, fatty pancreas. And even, even in young patients, young females with PCOD, we see this fatty changes in pancreas, which should not be there for that age related fatty disease, fatty deposition should not be there at that point of time. So insulin resistance, the fatty infiltration is definitely correlated. And I think the largest spectrum of metabolic dysfunction spectra disorders, that these are all getting into that. Actually, so we need to explore further in our preventive radiology OP in the future OPDs also. So once again, I wish to thank you for the wonderful lecture, and thank you once again for joining us, and we request you to be in the preventive radiology OP in the future too. So I wish to thank Dr. Gaurav Mehta, Dr. Sharad Maheswari, and Dr. Egambaram for the talks, and Dr. Heman Patel for the inaugural address. So with that, it is time to say goodbye from Preventive Radiology OP as an initiative of Preventive Radiology of National IRIA, Indian Radiological and Imaging Association. Egambaram, you want to say?
Yeah, Doctor, at the outset, let me thank all of you for this great platform to exchange, various possibilities under the preventive OP, as well as, looking at various modalities. I also would like to appeal, Dr. Sharad, to look at the changes that has happened in shear wave elastography over the last couple of years, especially with the new technology, which give a lot of correlation between MR as well. And that is something I think stated by Dr. Nitin Chaubal in the last talk. And I think it also, as Dr. Rijo said, it is a viable option when you're looking at the pan-India basis under the preventive screening model. So with this, I would like to once again thank Dr. Rijo for this great opportunity, and IRA, and as well as Dr. Heman Patel for this great inauguration. Thank you one and all, and thanks from Mindray for this nice program.
One thing, Rijo, you have been really doing great work. So KGF4, I would like you to be the star.
Thank you, Sharad. Thank you.
Bye-bye.
So it's time to say goodbye and good night. And
good night.
Thank you.
We are signing off. Thank you. Thank you all.
Thank you also. Thank you, sir. Thank you, Dr. Rijo. Thank you.